Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. I'm here today with Dr. James Tabibian, who is going to talk to us about vancomycin. Dr. Tabibian, do you want to tell us what your area of expertise is and who you're currently working for?
I'm a gastroenterologist by training and also an advanced endoscopist by training. After a 5-year research-oriented fellowship at Mayo Clinic, I did a year of advanced endoscopy training, meaning I do procedures to get inside the bile ducts, image the bile ducts, and do a various number of other things. That was at University of Pennsylvania. And then at the end of training, I came back to what's probably my home state of California. And I'm now at Olive View-UCLA Medical Center in Southern California. I'm the director of endoscopy here. I'm also the residency research director. And I have kind of two main interests. One is bile duct disorders, and really probably specifically PSC and other stricturing disorders of the bile duct, benign or malignant. And then I also really like endoscopy in its many forms, whether it's from above, from below, or going through tracts that people didn't know that we put endoscopes through. So that's kind of me in a nutshell.
And does that include when ERCP, or is that's separate?
Definitely, yeah. So ERCP, at least in the U.S. and many other countries, is considered an advanced endoscopic procedure. So ERCP is kind of my, from a technical standpoint, my baby. I really, really like ERCP and really like challenging cases and really thinking deeply about ERCP in each individualized patient, in addition to kind of the main fundamentals. But obviously, ERCP is critical to the management of many bile duct disorders, especially or including PSC. So yes, absolutely.
Yeah, because you kind of have to be a good driver for that stuff, isn't it? Because it can go wrong very easily.
Yeah, it can, and it's a packed freeway or highway with a lot of turns and oncoming traffic sometimes. So yeah, gotta be a good driver.
I guess we'll get back to a little bit more about ERCP, but I think the first thing to talk about really is vancomycin. And if you're on the news groups, people are very excited about this. And, I understand their excitement, but because people are hoping that it'll work for them. But there's been very few actual studies done with vancomycin so far. Is that correct?
Certainly not as many studies as, let's say, aspirin in coronary or in heart disease, but there have been a few now, none of which have been particularly large or in number or in years of follow-up, in part due to the rarity of PSC and the challenges of funding a large and long study. But yeah, there is a handful based on which I think a lot of folks are quite excited about its potential in PSC.
Can you explain what vancomycin is being used for and why with PSC?
Sure. So I imagine a lot of folks don't know what exactly vancomycin is. So if you would just bear with me, let me just comment on that. So it's an antibiotic. It's produced by a plant, actually, and it's a very, very large molecule. So large that if you swallow it or you eat it, it actually will go through your digestive tract and not be absorbed essentially whatsoever. And it's a I guess you could call it a kind of a complex molecule in addition to being large. It has 3 different rings to it. It has some sugar groups added to it, and it's actually a protein or a peptide as well, but not a protein in the sense that it's not made the way that human or mammalian proteins are made. That's probably not that important to know, but it acts by inhibiting proper cell wall formation in certain bacteria, specifically gram-positive bacteria, so the bacteria that stain positive in gram staining. And there are trillions, if not more, of those types of bacteria in the gut. And so because it's thought that PSC is a hallmark of PSC is an abnormal biology or homeostasis or lack of homeostasis of the intestinal bacteria that may be modifying the intestinal microbiome at large might help bring homeostasis back, or what's called a eubiotic microbiome. U be spelled EU, meaning good in Greek. So as opposed to dysbiotic, DYS, biotic. So the limit data that are available both in pediatrics as well as adults suggest that by taking vancomycin by mouth, so that it works in the gut and not IV, which would have different effects, it seems to decrease inflammation, slow down scarring, and improve laboratory test values, and sometimes also decrease symptoms such as itching in a subset, at least, of patients with PSC. Not necessarily 100% of patients, but at least a proportion that's large enough that, given the overall safety of vancomycin, it's, I think, something to be excited about in the PSC world. So that's kind of been the experience so far, that it might help to slow down or kind of slow down the disease, PSC, or kind of put it into a quiescent state, kind of a dormant state, as long as you're on the medication.
And this is because we're kind of learning that PSC, I mean, it's quite new, really, isn't it? But we're kind of learning that PSC is probably, as you say, like a imbalance of the microbiome.
Yes, exactly. I think it's probably more complex than just microbiome is off and therefore you get PSC, because you might imagine that many people have an imbalanced microbiome, especially since given kind of the way that we've been eating in Western societies. Yet only a small handful of people, maybe 30 in 100,000 or 10 in 100,000 develop PSC.
Because I saw another study recently where they were talking about doing, I think it's in Denmark or in Norway and also in Japan, where they've kind of isolated certain bacteria that they've been able to introduce to mice and to actually induce PSC in the mice, in healthy mice. Which I know is bad news for the mice, but good news for us, I think. With vancomycin, what they're doing is what you guys are doing is you're prescribing it on a kind of an ongoing basis. Is that correct?
Yeah, I would say the majority of gastroenterologists or hepatologists are reluctant to use it because we still don't know a lot about how it works and if it works and what its long-term, impact is. But those of us who do believe in at least giving it a go tend to use it longitudinally or on an ongoing basis, as you said, because it's actually been shown in at least the pediatric world. And also, I would say in the pediatric world more than the adult world, that when you withdraw vancomycin from a patient whom there was a good therapeutic response, things actually go bad again. The itching comes back, the labs go up, there's more pain. So, that's correct. It is on an ongoing basis at least currently.
And is it what are the sort of dosages you're talking about? They're low dosages, are they?
Yeah, they're pretty low dosages. I mean, it's usually a few hundred milligrams a couple times a day. So maybe 500, 750, 250. We really don't know yet what is the ideal dose. Should it be based on a person's body mass? Should it be based on, something else? But I have heard of higher doses being used when the lower doses don't work. And at least in some of those cases, the higher dose actually does result in the beneficial effect that's desired, rather than just saying we're giving you more drug but we're not seeing an effect. So I've heard of doses as high as close to 3,000 milligrams a day. But I've personally never done that.
And is there not a danger that if you do that, then that you will become resistant to antibiotics?
Yeah, I think you're hitting on one of the main concerns is that long-term exposure to really any antibiotic runs the risk of selecting for resistant bacteria or organisms. So in this case, perhaps the one that comes to mind is something called VRE, vancomycin-resistant enterococcus, which is a pretty nasty bug. But on the bright side, from what I understand, I don't think there have been any cases of VRE linked to vancomycin use in PSC. And maybe that's just because the total number of patients, the denominator hasn't gotten big enough yet. Or maybe because it's safe.
Are you also trying to, is vancomycin one of the sort of drugs that is in people's arsenal to try and, because there's a lot of antibiotics out there in general, isn't it? Is Vanco one of the drugs that you use to in an emergency type of thing?
Well, vancomycin, I guess the short answer there would be yes, but there are, in most instances, other drugs that we use, other antibiotics that we use in emergency situations, because vancomycin is relatively narrow in its spectrum of what it actually works on, as compared to, let's say, ciprofloxacin or levofloxacin or Zosyn, some of the other kind of potent antibiotics. So yes, you do want to conserve any antibiotic you can conserve. You don't want to breed resistant organisms, but I think Vanco is probably lower risk than some of the others in terms of losing out on a drug that you would want to keep in your arsenal for emergencies.
And is there any effort to sort of isolate, or refine vancomycin to be more specific towards the PSC microbe?
Now you're thinking like a scientist or a researcher. So one of the things that's interesting about vancomycin and others in the PSC world might know more about this than I, because of their vested interest specifically in vancomycin, is that there are now, at least in the U.S. and I believe in other countries worldwide, numerous different formulations or versions of vancomycin from different manufacturers. And so to your point, it seems that only some of them really work in PSC, others don't, which might make you think, well, then is it really the vancomycin? Is it the care that's in, or the suspended solution it's in? Is it the combination of the two? And then, so there are studies that are planned or that are hoped for that very regard. In addition, I think we need to figure out, irrespective of the brand of vancomycin, who are the patients that are going to actually have a good effect from it, and maybe who are the ones that are not, don't derive any benefit or are harmed. Is it the patients that have PSC as well as inflammatory bowel disease, right, who do well with it? Is it the adult patients that are diagnosed early, and as well as the pediatric patients? So there's a lot of questions that still need to be vetted, or a lot of fine tuning that we need to do to improve our understanding and determine how best to apply the medicine.
Most people who have PSC are very familiar with taking antibiotics, but they tend to, but more like, I think they would carry something like Cipro with them in case they get a cholangitis attack. But they are prone to wiping out all of the good bacteria in your stomach as well as the bad bacteria. Is there a danger with that with vancomycin as well? Like, does it affect everything?
No, it's really not a broad spectrum antibiotic the way ciprofloxacin is, and there aren't, from what I know, a lot of gram-positive bacteria in the stomach, or even above the level of the colon, from what I know, vancomycin harms in a clinically significant way. So it's not, the level of concern is not the same, in terms of wiping out the good bacteria the way that, let's say, Cipro would do. It's a much lower concern.
Looking ahead now, say to 2 or 5 years ahead, is it likely that we'll have something like vancomycin with possibly Nor-Urso or some sort of compounded drug, together with an anti-inflammatory, say, that might be able to treat the disease in a way that it's not been treated before?
I think 2 to 5 years or so would be very ambitious. I wish that's how fast things would move, but I mean, it takes years just to test Urso or Nor-Urso, let's say, its homolog Norurso being the homolog to ursodiol or UDCA. So I think that the thought of combining that with vancomycin and maybe even a third drug, either as a combined capsule or as just a combined therapy with multiple capsules taken once or multiple times a day, that's, I think, going to be years down the road unless something changes in that, funding is easier to come by, the drug is being donated, and then there's a pool of patients lined up who qualify for the study who are ready to start. But I think that's my hope. I believe that PSC is so heterogeneous from one patient or even one country to another that if we just work on treating it with one medicine, we're probably going to end up not being able to help a large proportion of patients. Just like hypertension, blood pressure. If there were only metoprolol or atenolol, boy, there's going to be a lot of patients who have hypertension ongoing with its, and its long-term complications, because we know that that's not the right drug for every patient. That's a relatively simple problem, high blood pressure, let alone something like PSC.
I mean, there is a lot at stake, though, isn't there? Because currently with the the transplant being the only sort of viable treatment, it's not even. It seems that the recurrence is quite high of PSC in transplanted patients as well. So, you could be talking about 2 transplants in a lifetime or young lifetime. That's an expensive game.
Very expensive, very high risk, high stakes. So yeah, there's definitely a critical need. If this were a much more common disease, I would say this would be all over the news. I mean, it's but because it's less common, it's difficult to engender broad enthusiasm, especially among people who don't know about the disease or not infected by the disease. But for those who have it and their loved ones, their friends, their family, this is a major area of need in the biomedical field.
And yet it's sort of more common than diseases like cystic fibrosis, isn't it? Or am I wrong there?
I don't know off the top of my head the clinical epidemiology of cystic fibrosis. Look it up real quick. But I think, though, irrespective of how common cystic fibrosis is, it's a disease that I think is under-recognized, underdiagnosed. I think it really is much more common than people realize. And in part because it's doesn't make as much noise, if you will. It's not as loud as a disease like cystic fibrosis, where you're literally coughing your lungs out practically. Whereas with PSC, you might be developing liver failure or a liver cancer of one sort or another in the background while you think everything is hunky-dory. But then there comes a day where your eyes turn yellow and you become jaundiced, or a patient becomes jaundiced, and there's a major problem, either liver failure or incurable liver cancer. So I think, yeah, you're right that it's not that rare, but the data at least suggests that it's pretty rare. But I think it's more common than we know, and I think it's probably becoming more common over time.
I think I spoke to somebody at the conference from Norway, and they said that they screen everybody with UC for PSC, and that that's made a big difference.
I think that's brilliant. I mean, in Norway, I believe PSC is the number one indication for liver transplantation. So it's actually not that obscure or esoteric of a disease. It's frontline liver disease. So we're not quite at that point yet in the U.S., but perhaps as screening tests become more readily available and cheaper and reliable, we might go that route.
Wonderful. And finally, just because it is your passion, how advisable are ERCPs in PSC?
That's a good question. Yeah. So I might be I might be in the minority when I say that. ERCP should not be taken lightly in PSC, nor do I think that every patient with PSC needs an ERCP. I also don't think every patient with PSC needs kind of an annual or every 6-month kind of clean out of the ducts. I think that was an older mentality or older mindset by some folks. So the people who do need the ERCP, I think should get it. should undergo it. The question might be, well, who really are those folks? And I think it's the people who have unexplained progressive worsening of their serum liver tests, or increases in their, or a new increase in their serum tumor marker, CA19-9, or carbohydrate antigen 19-9. It's also the people who, on an imaging study, like an ultrasound or a CAT scan or an MRI, have what's called a dominant stricture. So while you have all the kind of smaller strictures that might be characteristic of PSC, or at least large PSC, now all of a sudden there's a big dominant kind of central out of proportion stricture. That should undergo an ERCP for two reasons. One, to try to determine, is the stricture benign, or is this a cancer that's manifesting? And so you would get some brushings or biopsies or do some other tests to try to make that determination. And secondly, to potentially place a stent or dilate the stricture, or both, so that bile flows better and the symptoms of the stricture, or the signs of the stricture, such as the laboratory test abnormalities, improve. So I think it is an important tool, but it should really be used when non-invasive means are insufficient or not applicable or inconclusive.
Yeah, and I guess it also depends on who's driving as well, isn't it? Because it's a very easy thing to I think pancreatitis is quite common after ERCPs if they don't go according to plan.
Yeah, I mean, there's about an 8%, maybe 5 to 10% is the range, risk of acute pancreatitis. Patients with PSC, depending on what study you read and who you ask, also have a somewhat higher risk of cholangitis, acute cholangitis, post-procedure within a few days, because you inject contrast into the bile duct as well as other non-sterile liquids. And if you're not very meticulous about emptying all of that out at the end of the ERCP, which can be very tough to do in PSC as compared to someone who has normal bile ducts but maybe just has one stone, that becomes a nidus for infection and sets people up for infection after ERCP, which potentially means a new course of antibiotics, another ERCP, another presentation to the emergency room or the hospital. So it really should be done with a good amount of what's the right word? Scrutiny. When it's needed, it should be done. Shouldn't really waver, but should also be careful to not do it without a good indication because of the risks.
Wonderful. That's been really helpful. And I suppose these are the questions one should ask when getting them. Are these measures being taken? And also, I think it has something to do with how many you do a year, isn't it? If you like anything, practice makes perfect.
I agree. And not only how many you do a year, but how many you do in PSC a year actually matters, because PSC is kind of, it really is, and maybe I'm biased, but I think just as objectively as I can say, it's a unique disorder. So not every ERCP is similar. PSC ERCPs, I think, have special considerations that unless you see a lot of PSC, you may not appreciate the subtleties that are involved. So yeah, you should go to someone who does a lot of ERCP, preferably at an academic center, if you were to ask me, or someone, if not in an academic center, at least someone who sees a lot of PSC, which is unusual in the private practice, non-hospital-based setting.
Wonderful. Well, is there anything I didn't ask that I should have asked about vancomycin in particular, or anything that you'd like to add?
I think, great questions. These are all the questions I think I would be asking as well. It's kind of frustrating for us as providers or as researchers how slow things move. But hopefully we'll keep things moving forward and faster than previously. And I think vancomycin is still of interest. I think we will see more data about it. And I'm hopeful that even if it doesn't work in all patients, there will be more acceptance of using it, at least in those who seem to be benefiting from it. Based on various parameters. And I think happy to do this again at a future date once we have some more data to go over. And I think that's all I have.
Well, things are moving very quickly, so I'd be very happy to check in with you again. I guess finally, if somebody, because I've seen on the news groups that people are sort of going after vancomycin themselves, if they can't find it, it's very expensive in the United States. There's people in Europe who are, say, if it's not available in Switzerland, they'll go get it in Serbia or Croatia and stuff like that. If people are doing that sort of stuff, I guess what would your warnings be in those, given that there are different types of vancomycin that seem to be working better than others?
I mean, I guess there would be all the warnings of just vancomycin in general would apply, but in addition, make sure what you're getting is actually working. So, if you have no other recourse but to go to Serbia or whichever country to get your vancomycin, you're probably going through some financial strain, if no other means of trouble, to get it. And you should check in with labs, imaging, whatever it is, and try to get an objective assessment of if it's actually working. So if you're taking it for 3 months and you feel no different, and your labs are no better, and your imaging, although 3 months might be a little early to see imaging changes on MRI or what have you, but nothing is moving in the right direction, I might say it's probably not working for you, at least not that brand or not that dose. And you might, be well served by trying to look for a clinical trial in which to participate, or find a provider who is more comfortable with prescribing and obtaining vancomycin for you.
Well, that's really great advice. Doctor, thank you very much. This has been really helpful, and I look forward to chatting with you again sometime soon.
Perfect. My pleasure.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.